Diabetic neuropathy is a group of syndromes caused by damage to the peripheral and autonomic nerves, often linked to high blood sugar or insulin resistance. While most people are familiar with the common forms such as distal symmetrical and autonomic neuropathies, there are other less frequent types that can have a significant impact on quality of life. In this video, we'll explore diabetic mononeuropathies and diabetic amyotrophy, discussing their causes, symptoms, and treatment. By understanding these conditions, patients and caregivers can better recognize symptoms and seek timely care, improving outcomes and reducing unnecessary worry. Mononeuropathies refer to nerve damage affecting a single nerve. In diabetes, these can involve cranial nerves, peripheral nerves, or nerve roots. Unlike more common diabetic neuropathies, mononeuropathies are not directly related to long-term blood sugar control and often resolve on their own. However, their sudden onset and sometimes severe symptoms can be alarming. Recognizing the difference between mononeuropathies and other neuropathies is crucial for accurate diagnosis and management. Let's look at the types of mononeuropathies that can occur in people with diabetes. Cranial mononeuropathies are the most common form of diabetic mononeuropathy. They typically affect the nerves that control eye movement, especially the oculomotor nerve. Patients may experience double vision, drooping eyelids, or difficulty moving the eye. These symptoms can develop suddenly and are sometimes preceded by pain around the eye. Despite their dramatic presentation, cranial mononeuropathies and diabetes usually resolve within a few months, often with minimal or no lasting effects. Understanding these features helps distinguish them from other, more serious neurological conditions. Third cranial nerve or oculomotor nerve is most commonly affected in diabetic cranial mononeuropathy. Patients often notice abrupt onset of double vision and drooping of one eyelid, sometimes after a few days of pain above or below the eye. A key feature is that the pupil's response to light is usually preserved, which helps differentiate diabetic third nerve palsy from other causes. Most cases resolve with time, and further investigation may not be necessary if the patient has diabetes and no other neurological symptoms. Besides the third nerve, the fourth trochlear and sixth abducens cranial nerves can also be affected, though less commonly. These mononeuropathies usually occur in older adults and can cause problems with eye movement, leading to double vision. Unlike third nerve palsy, pain is less common and less severe. Recovery is typically complete within 3 months. However, because these nerves have long courses inside the skull, it's important to rule out other causes with appropriate tests or specialist consultation. Diabetes increases the risk of Bell's palsy, a sudden weakness or paralysis of the facial muscles on one side. This condition affects the muscles of the forehead and face, making it difficult to smile or close the eye on the affected side. The absence of taste loss suggests the nerve damage is beyond where the taste fibers branch off. Bell's palsy and diabetes typically resolves with time, but recognizing it early can help avoid unnecessary anxiety and ensure proper management. Entrapment neuropathies occur when a nerve is compressed in a narrow anatomical space. In diabetes, nerves are more vulnerable to pressure due to changes in connective tissue and pre-existing nerve damage. Common sites include the wrist, elbow, and lower limbs. Symptoms can range from pain and numbness to muscle weakness. Early recognition and management can prevent permanent damage and improve quality of life. Let's explore the most frequent entrapment neuropathies in diabetes. Carpal tunnel syndrome is the most common entrapment neuropathy in people with diabetes. It occurs when the median nerve is compressed at the wrist, leading to pain, tingling, and numbness in the palm and fingers. Symptoms often worsen at night and may be relieved by shaking or hanging the hand off the bed. Advanced cases can cause muscle wasting and weakness, making it hard to grip objects. Treatment ranges from splinting and physical therapy to surgical decompression if symptoms are severe. Ulnar nerve is especially susceptible to compression at the elbow, leading to numbness and tingling in the ring and little fingers. Severe cases can cause muscle weakness and wasting in the hand, resulting in a claw-like appearance. Early symptoms may be managed with physical therapy and avoiding pressure, but surgery may be necessary if muscle weakness develops. Accurate diagnosis is important to ensure the right treatment and prevent permanent hand dysfunction. Radial nerve compression can occur in the upper arm or wrist, sometimes called Saturday night palsy or handcuff palsy. This leads to pain and numbness on the back of the hand with minimal muscle weakness. Most cases improve with conservative measures such as removing the source of pressure. Surgery is rarely needed. Recognizing the symptoms and their causes can help patients avoid further nerve injury and recover more quickly. The lower limbs, nerves can also be compressed, leading to pain, numbness, or weakness. The most common is compression of the lateral cutaneous nerve of the thigh, causing myalgia paresthetica. This results in burning pain or numbness on the outer thigh. Other nerves like the femoral and peroneal can also be affected, leading to muscle weakness or foot drop. Treatment focuses on relieving pressure and physical therapy, with surgery reserved for severe cases. Compression of the femoral nerve can cause pain, numbness, and loss of sensation in the front of the thigh. Muscle weakness may develop, especially in the quadriceps, making it difficult to climb stairs or stand up from a chair. Physical therapy is essential to maintain and restore muscle strength, and most patients recover with time. Early intervention can prevent long-term disability and improve mobility. Peroneal nerve, located near the knee, can be compressed, leading to numbness and weakness in the foot. In severe cases, this results in foot drop, making it hard to lift the front of the foot and increasing the risk of tripping. Treatment involves removing pressure from the nerve and engaging in physical therapy. Surgery is rarely needed, but early recognition and management are key to preventing falls and injuries. Compression of the posterior tibial nerve in the tarsal tunnel, located near the ankle, can cause pain, tingling, and numbness on the sole of the foot. This condition, known as tarsal tunnel syndrome, is less common but can be disabling if not treated. Management focuses on relieving pressure and physical therapy, with surgery considered only in persistent or severe cases. Early diagnosis can help patients regain comfort and mobility. Rare cases, diabetes can cause mononeuropathies involving nerves like the phrenic, long thoracic, or obturator nerves. These may present with unusual symptoms, such as breathing difficulties or weakness in specific muscle groups. The causes can include external pressure, nerve infarction, or simply high blood sugar. While uncommon, recognizing these rare presentations is important for accurate diagnosis and appropriate care. Diabetic radiculopathy involves damage to a single nerve root, often in the chest or abdomen. Patients experience sudden severe pain on one side which does not cross the midline and is often worse at night. The pain may be accompanied by changes in skin sensation or muscle weakness. While the condition is self-limited and usually resolves in weeks to months, it can be mistaken for other serious problems, such as heart or abdominal disease. Proper diagnosis is essential to avoid unnecessary tests and anxiety. Hallmark of diabetic radiculopathy is rapid onset of severe unilateral pain in the chest or abdomen. The pain follows a specific nerve root distribution and does not cross the body's midline. Patients may also notice changes in skin sensation, such as numbness or hypersensitivity, and in severe cases muscle weakness or bulging of the abdominal wall. These symptoms can be alarming, but most cases resolve within 6 to 12 weeks with symptomatic treatment and reassurance. Diagnosing diabetic radiculopathy involves a careful clinical assessment. The pain's distribution, lack of midline crossing, and associated sensory changes are key clues. However, because these symptoms can mimic serious conditions like heart attacks or abdominal emergencies, additional tests may be needed to rule out other causes. Electrophysiological studies can confirm nerve involvement. Once diagnosed, patients can be reassured about the generally good prognosis. Treatment for diabetic radiculopathy is mainly symptomatic. Pain relief is the primary goal, and antiplatelet therapy may be considered. In severe cases, a local anesthetic block can provide relief. Patients should be reassured that the pain will usually resolve within a few weeks, but they should also be aware that recurrences can happen. Early diagnosis and appropriate management can prevent unnecessary worry and medical expenses. Diabetic amyotrophy is a rare but distinctive form of diabetic neuropathy affecting the upper and lower lumbar plexi. It is also known as Bruns-Garland syndrome, proximal diabetic neuropathy, or femoral sciatic neuropathy. This condition typically presents with severe pain, muscle weakness, and wasting in the upper thigh, often accompanied by significant weight loss. Unlike other neuropathies, diabetic amyotrophy can be very disabling and requires intensive rehabilitation for recovery. Diabetic amyotrophy usually affects men over the age of 50, often with mild or recently diagnosed type 2 diabetes. A history of significant alcohol intake is common. Patients may lose up to 40% of their body weight and experience severe upper leg pain, depression, and emotional changes. The combination of rapid weight loss and severe neuropathic symptoms can raise concerns about underlying cancer, so thorough evaluation is important. Examination: diabetic amyotrophy is marked by severe muscle weakness and wasting, especially in the pelvic girdle and front thigh muscles. Patellar reflexes are often absent, and there may be evidence of distal symmetrical polyneuropathy. Patients struggle to climb stairs or rise from a chair. These symptoms are most severe in the first 6 months and gradually improve with time and therapy. Recognizing these features is key to early diagnosis and management. Biopsies in diabetic amyotrophy show multiple nerve pathologies, including ischemic injury, fiber loss, thickening, and signs of inflammation. Nerve conduction studies and EMGs reveal both motor and sensory involvement. Some research suggests an immune-mediated inflammatory process, but immunotherapy has not proven effective. Understanding the underlying pathology helps guide treatment and set realistic expectations for recovery. Cornerstone of treatment for diabetic amyotrophy is achieving good blood sugar control, often with insulin. High-protein, high-calorie diet helps restore weight, and abstaining from alcohol is essential. Physical therapy is the most important intervention, with the intensity of rehabilitation directly linked to the degree of recovery. Addressing depression and neuropathic pain can also improve rehabilitation outcomes. Opiates are reserved for severe, persistent pain. Most patients with diabetic amyotrophy experience severe symptoms for the first 6 months, with gradual improvement over 1 to 3 years. Weight loss usually resolves within a year, and muscle strength may continue to improve for up to 3 years. However, full recovery is not guaranteed and depends on adherence to therapy. Early and intensive rehabilitation offers the best chance for regaining function and independence. Neuropathic cachexia is a rare syndrome related to diabetic amyotrophy, characterized by severe weight loss, pain, and emotional changes. It often occurs in older adults with mild diabetes and may be mistaken for cancer or other serious illnesses. The mainstay of treatment is supportive care, including nutritional support, pain management, and psychological support. Recognizing this condition can prevent unnecessary investigations and help focus on effective therapy. For most diabetic mononeuropathies, the primary approach is watchful waiting, as many cases resolve on their own. Physical therapy can help maintain muscle strength and function, while surgery is reserved for cases where nerve compression causes significant weakness or disability. Early intervention and patient education are key to preventing complications and ensuring the best possible outcomes. Prognosis for diabetic mononeuropathies is generally excellent. Most patients recover fully with little or no residual pain or weakness. The exception is diabetic amyotrophy, where recovery depends on the intensity of rehabilitation and adherence to therapy. Early diagnosis and reassurance can reduce stress and prevent unnecessary medical investigations, helping patients focus on recovery. Recognizing the distinctive features of diabetic mononeuropathies and amyotrophy allows healthcare providers to reassure patients, avoid unnecessary tests, and start appropriate therapy early. This not only improves outcomes but also reduces anxiety and healthcare costs. Patient education is essential for empowering individuals to seek help promptly and participate actively in their recovery. Summary: diabetic mononeuropathies and amyotrophy are less common but important complications of diabetes. They can cause sudden severe symptoms but usually have a good prognosis with proper management. Early diagnosis, patient education, and intensive rehabilitation are key to recovery. By understanding these conditions, patients and caregivers can approach symptoms with confidence and optimism, knowing that most cases resolve with time and care.